offer to come up from Bristol to chair the session. I greatly appreciate it. And thank you for coming in from the lovely sun, and for those of you who haven't been here earlier today, for coming this afternoon for my talk. We don't often talk about ethical issues in psychiatric diagnosis. We had a talk earlier about the ethics of randomized controlled trials by a colleague of mine, but we don't often hear discussion of this, and it's something that I have been thinking about for the last few years, as I have been discovering that junior doctors, when you give a patient with a certain constellation of symptoms, will invariably say, I have looked at DSM-IV and I think this person has got major depression, or I think this person has generalized anxiety or some other disorder, and you say, hang on a minute now, what's the context in which you're making this diagnosis and in which these symptoms have arisen? And they invariably look at me in a strange way and say something like, well, what do you mean the DSM says this? So, the DSM is really what I'm going to talk about. DSM stands for Diagnostic and Statistical Manual. It's very appropriate that I should be talking about classification at this lecture, which I'm honoured to have been invited to present to you. Anscombe, as you all know, I'm sure, translated some of the works of Wittgenstein, and they remain lifelong friends. And she, after her death, was buried in a plot across from where he is buried, so they ended their lives together, and he was a lifelong mentor to her. And Wittgenstein talked about the classification of psychiatric disorders, believe it or not. He said, classification made by philosophers and psychologists as if one were to classify clouds by the shape. And a writer recently in World Psychiatry commented that that was a very appropriate metaphor, because psychiatric diagnoses are fuzzy. They tend to measure imperceptibly with each other. They tend to drift and change over time, and that's a huge challenge for psychiatry. Now, the plan of my talk is I'm going to start by giving you a history of how disorders are classified in psychiatry. How do we arrive at all these diagnoses that we've heard about over the last few days? How can we demonstrate their existence? What are the problems with the current diagnoses that are around? And what are the implications, the ethical implications of those for patients, for society, and for the profession? And finally, an attempt to explore briefly what can be done about them. I want to tell you about my interests and confirm my declarations. I don't do drug trials, so I don't get paid for drug trials. I've received speakers' fees mainly from Lundbeck and Pfizer in recent years. I'm a practicing psychiatrist in a public hospital. I still practice psychiatry in a public hospital. I run the self-harm service in the Mater Hospital, which is the biggest service, the biggest self-harm service in the country. We see about 1,100 self-harm patients per year. By British standards, that may not seem very much, but when you live in a country with a population of about 4 million, it's a lot, and it's the biggest in the country. I make psychiatric diagnoses. I believe psychiatric diagnoses are important. Some people might straight away accuse me of engaging in labelling theory and stigmatizing people, but I believe for a variety of reasons that it is important to make psychiatric diagnosis. I believe that a diagnosis is important when we are attempting to arrive at a treatment plan. If we didn't have psychiatric diagnoses, we would have nothing to guide us in how we would deal with a particular person. We wouldn't be able to test what the evidence for particular interventions were if we didn't have broad diagnoses around which to try and develop those. I prescribe medications. I would be willing to have antidepressants if there were, or anti-anxiety medications, or antipsychotics if I needed them. I believe in applying medical and social science research techniques to psychiatry, and I am not a member of an anti-psychiatry group, nor am I a member of critical psychiatry, which is a group that exists within current psychiatric practitioners. So I'm proud to be a psychiatrist. That's not me, by the way. not my body. But there are difficulties, and there are huge difficulties with the current psychiatric classifications. So in case you think that I'm coming to this as a person who is absolutely wedded to the current psychiatric diagnosis and the current system of diagnosis, I am not, and I want to assure you of that, but neither do I believe that psychiatry should be abolished. The problems begin with the definitions that we use, and they're really all a bit circular, and sometimes they're used interchangeably, and that creates a problem for everybody. We've created a number of disorders, so I think the start, and most of the disorders are at syndromal level. So a syndrome has been defined as a collection or set of signs and symptoms that characterize or suggest a particular disease. Now, the first bit of that is fine. Collection or set of signs and symptoms that characterize something. The question is what the something is, and the definition that's provided in the dictionaries I was at was of a particular disease. So, what's a disease? A disease is a pathophysiological response to an external or internal factors, or it's a disorder of structure or function that will produce detectable illness or disorder. It's a completely circular diagnosis, but it's really focused on the pathophysiological and physical changes that can be detected. Now, I'm not sure what physical change one can detect in, say, a phobia. I suppose when the person is looking at, like me, I'm phobia of frogs, the frog, you know, you get a tachycardia, your heart will pound. But when it's over, there's nothing much to show. So I'm not sure where that would leave conditions like phobias, or indeed most psychiatric disorders for that matter. Disorder is a disruption to regular bodily structure and function. So a cardiac arrhythmia would be the consequence of a heart disease, in the same way that a delusion would be a consequence of a psychosis. So disorder is probably okay, it's an acceptable definition. And finally, illness is the condition of being sick or ill. But in psychiatry, we tend to intermingle and use these. Now, turning to the history of how we got to the state we're in with these definitions and with the specific disorders that we talk about in psychiatry. Until the 1950s, the focus was mainly psychoanalytical, and I know there are a number of people with psychoanalytical training. I had very interesting talks from some of you this morning. And the focus was mainly on explanation and understanding the background to the symptoms, the basis for the symptoms, in terms of psychodynamics and possibly relationships. But that changed in the 1950s because psychiatry was wanting to align itself very much with general medicine, with a medical approach to illness and disorders. And in that model, a condition has a cause. In the case of psychiatry, known or unknown, mainly unknown. But even still in medicine, there are major conditions for which the cause is unknown. I was speaking to Neil at lunchtime, and Neil's a neurologist, and his main interest is multiple sclerosis. And I was asking him if there had been any developments in understanding the etiology, the causes of multiple sclerosis, and Neil answered, no, not very much at all, even though there are active developments in treatments, but not in understanding cause. So psychiatry is very much in that area. So the thinking is, in any event, that the cause results in symptoms, and then in a course over time, or in a particular response to treatment. And you need, in order to demonstrate in psychiatry that a condition is what we call valid, you need to be able to ideally show what the etiology is, what the symptoms, and what the process is. And then, of course, as a result of that, we give treatments that are at this point known, or in some cases unknown for some of the conditions. The approach to symptoms, which is the second component in that model, was first talked about by Jaspers in his book General Psychopathology in 2013. Now, when I was training in psychiatry in Nottingham, I trained under one of the professors. There was Professor John Cooper. And John Cooper was heavily into, David was nodding his head, you know of him. John Cooper was heavily into psychopathology and Jaspers. And I remember a month before I was about to sit my membership, he said to me, and the group that he was giving a tutorial on some aspect of psychopathology to us, he said, you should all read Jaspers in German before your membership. Now, not only does any of us not speak German, but we were a month away from our exam and reading, and the book is quite big. It's a bit like a telephone directory, hadn't been translated, so that was a problem. We didn't read it, we still passed. And anyway, his approach was the phenomenological one. And phenomenology is the study of experiences of consciousness from the first person point of view. So it's a study of what the person says they are experiencing, whether it's low mood, whether it's a panic attack, whether it's fear of frogs, fear of flying, or whether it's a delusion, although the person may not identify it as a delusion. The person may identify it as a belief that he's infested by the devil, or a belief that he is being followed by the CIA or by the Russians, although maybe with the Russians it's not so much a delusion anymore, but that he is being followed by something that manifestly is not true. And Jaspers believed that these could result in psychological reactions, which could then become disorders. He didn't define a disorder specifically, but they could become something abnormal. And so the approach to psychiatric illness has been largely a phenomenological one, where you identify groups of symptoms and you see how they cluster together. That's called the phenomenological approach. And that really hasn't changed since the 1950s, except it has become much less well taught to students, and in particular to doctors in training in psychiatry. The psychiatric classifications don't go into it a huge amount. They sort of have broad definitions or broad categories like delusions of persecution, but they don't explore them in any depth. So the training and teaching around phenomenology has declined even since I was fortunate to train under John Cooper, who had lots of tapes of people describing their symptoms, and he would explore the particular symptom in depth, and he developed a diagnostic instrument called the Present State Examination for the World Health Organization, which explored these phenomena in great detail. So I was fortunate to have studied under him and to be able to explore these symptoms and to tease them out. But that doesn't happen with the trainees now, and they sometimes, as a result, use the language of phenomenology inappropriately. So they will say somebody has an obsession, when they mean that they're really worried about something and preoccupied by something. But an obsession has a particular meaning in psychiatric phenomenology. So it has largely remained phenomenological, as I say, and that has become quite lax in recent years. One of the reasons why it was felt we needed to tighten up on classifications and have a book and books in which we classify disorders was because until the 1960s, agreement between doctors when discussing patients and diagnoses was very low. So one psychiatrist would diagnose a person as having bipolar disorder. The same doctor would say the person had schizophrenia. The same person might say that the person had what we call paraphrenia. So diagnosis was very unreliable, and there's a very well-known study called the US-UK Diagnostic Study, in which a group of psychiatrists from the US and from Britain were given case vignettes of a number of patients, 50 or 60 patients. And they found that the UK patients diagnosed them largely as having bipolar disorder, and the Americans diagnosed them largely as having schizophrenia, even though the vignettes were exactly the same. And that's an example of poor reliability. And so it was felt that that needed to be rectified, so that first doctors, physicians could talk to each other, describe patients. So when you described somebody, the person you were talking to would understand what you were saying, and the kind of picture, the clinical picture the person had. And secondly, so is that if you could get good reliability between clinicians, you could perhaps more clearly identify patient groups who were the same symptoms, and look at different treatments in those groups, and have randomized trials and intervention studies for them. And so it was felt that the disorders needed to be classified more carefully. Unfortunately, what was sometimes thought to be the cause often was ultimately not shown to be the cause, and even today that's still the case. A case in point is post-traumatic stress disorder. A study published in 2005 examined a group of people with a large sample, over 100 people diagnosed with post-traumatic stress disorder according to the Diagnostic system, which was the ICD system. And the study was published in the British Journal of Psychiatry in 2005, and by a man called Moll, M-O-L. And what they found was that all of the people, of course, had the typical symptoms of PTSD because they had been diagnosed with it. But more than half of them hadn't had traumatic events. They had ordinary events like broken marriages, like illnesses, but they didn't have the traumatic events that you associate with PTSD, like traffic accidents, watching somebody die traumatically, those kinds of incidents. So there was a disconnect between the believed cause, the believed etiology, and the symptoms, and that's still a problem today. And so, as a way around trying to overcome the lack of reliability, it was decided that every condition that existed would be clearly defined, the symptoms would be clearly defined, and these became known as operational definitions. And they were specifically not based on the cause, so they were simply based on symptoms. So whether it was post-traumatic stress disorder or schizophrenia or a drug-induced psychosis, you would classify the symptoms but not mention anything about the cause, except in one or two conditions like drug-induced psychosis. But otherwise it was symptoms. And that first happened in ICD, is the International Classification of Diseases. And that is the World Health Organization book that lists all the conditions. The American one is called the Diagnostic and Statistical Manual. And ICD, the first publication of the psychiatric, ICD has always classified medical conditions. Psychiatric conditions were first added in 1949. And then so on, and ICD-11 is due out in 2018. You may have seen mention of it in the newspapers last week, where it was announced that gaming disorder was to be included as a psychiatric condition in ICD-11, and that is already being criticised. ICD-11 probably won't be, it's supposed to be out later this year. It probably won't, it may not be. It was originally supposed to come out in 2013, but it's been in gestation a long time. DSM, the first Diagnostic and Statistical Manual, which only applies to psychiatry, was published in 1952, and thereafter up until 2013. That isn't a typing error, by the way, in DSM-IV, changed from the Roman numerals to the whatever the other one is. They actually decided that DSM-IV was going to be a living, evolving document, and so they got rid of the Latin numerals, the Roman numerals. and they removed the hyphen. I don't know the thinking behind removing the hyphen, but I know they had a committee to decide it. Because they love committees, these groups, and we'll talk about the committees in a moment. So here we are, here are the classifications. And this is what they look like. This book is a relatively sensibly sized book. DSM-IV is huge. It's like two big telephone directories. This is the pocket version of it, and the pocket version with small font is 395 pages, and it's very small font. I mean, if I took off my glasses, I couldn't see it, and my glasses are for distance, not for close-up. It's tiny font, if you will. And there are 23 pages devoted to depressive disorders, so that's how much is devoted to depression. So we'll come through those, we'll talk about those in a minute. And in DSM-1, I'm focusing on DSM-1 because it's premature to focus on ICD level because it hasn't yet been finalised nor accepted by the World Health Organization. The DSM-1 had 268 entities entered under it. Some are major conditions, others are subtypes. So there would be depressive disorder with anxious distress, depressive disorder with mixed features, and so on. So there would be three. So there are 268 of those entities went out to 368. That's actually a reduction from DSM-IV of 6 entities. Excuse me. But what they have done, well, before we come to what they've done, there are 10 messages, by the way, waiting to be read. I've just been told. At the beginning of the deliberations on DSM-IV, it was predicted that by the time DSM-V came about, and that all psychiatric diagnoses would be identifiable by biological markers. And these would be genetic, or they would be based on neuroimaging and neurological markers, or they would be based on microbiological markers. Now, you'll come to see in a minute where we're at with that. When DSM-IV came about, and when that sort of assurance was made, assumptions were made by the profession, and particularly by people in the early stages of their training, and by the public. And you can guess what they are. It was assumed that these conditions that were being diagnosed, like major depression, like generalized anxiety, were living entities, that like cancer or like ulcers, they existed, you could see them, you could feel them, you could touch them. There was something, that they existed in physical space. It was assumed that they differed from other disorders, so that anxiety would differ from depression, and depression would differ from anxiety, and would differ from schizophrenia and bipolar disorder, and so on. They also made the assumption that they would differ from normal stress reactions, so that when somebody had an understandable response to a stressful event, that they could be clearly defined, that there was what's called a zone of rarity, a clearly defined demarcation zone between the two. It was assumed that they had a biological cause, that there was a specific symptom cluster, as I've mentioned already, and a specific course. Now, the symptom cluster, we've got the symptom clusters to the extent that we describe them. Whether they exist in reality is another matter, and whether they define a concrete entity is another matter. We don't know the cause for most, and we don't know the cause for most. We certainly know that it's very difficult to distinguish them from normal reactions to stress. Now I'll come back with an example of that in a minute. So, new diagnoses are proliferating. I just put gaming disorder up there because it's been in the news last week. It's in ICD 11, but I'm not going to talk about ICD 11 further. These are the new disorders that have come into DSM-IV from DSM. They're additional to those in DSM-IV. Overall, the number of entities, I said, declined slightly because they merged some of the DSM-IV ones. But these are the new ones, and interesting among them. My neurocognitive disorder has generated a lot of controversy because it's thought that that's probably normal aging, and it will be conflating normal aging with other neurocognitive disorders like Alzheimer's or atherosclerotic dementia. Hoarding disorder. Now, why hoarding disorder is a specific condition, I don't know. I mean, my husband hoards things that he, he hoards newspapers, he hoards books. But why it's not just left with OCD and just why it needs to be given a specific name. It's no different from any other kind of obsessional behaviour. Now, disruptive mood disorder, dysregulation. I have it here somewhere. It's kind of like grumpiness. It's slightly more than grumpy. It's bad grumpiness. Severe or recurrent temper outbursts manifest verbally and behaviourally. Physical aggression towards people or property. So, when you kick the door, that are grossly out of proportion in intensity or duration, observable by others nearly every day, occurring 2 or 3 times a week. It's a behaviour. What makes it a disorder? It might be just that somebody is bad-tempered. There are lots of bad-tempered people in the world. I kid you not. I mean, there are. And I don't think we should be necessarily regarding these as psychiatric disorders in a classification that need treatment. Maybe they do need treatment, but I think calling them, they may need help. But calling the disorder, I think, is a bit much. Caffeine withdrawal. Binge eating disorder isn't what you think it is. You might think it's bulimia nervosa. It means binging more than, I think it's twice a week or a month. Some such. The criteria, it's really very low, and this has received a lot of criticism. If you want to go online, and there are a number of people who've been active critics of DSM-IV. There's a man called Alan Francis. Now, Alan Francis was the chair of the committee for DSM-IV, and he has become a very ardent critic of DSM-IV and of some of these categories, among them binge eating disorder. Disinhibited social engagement disorder and reactive attachment disorder. There are 2 disorders of childhood that can persist into adulthood. They have appeared from nowhere. And then we have sleep apnea and some of those other ones that it's probably sensible to include. So there are all of these have come in anew, and we don't know really where they've come from. And as I said, they've 30-odd pages on depressive disorder in the pocketbook version, including among the other specified depressive disorders, depressive episode with insufficient symptoms. So depressive episode with insufficient symptoms is now now classified, let me see, item 311, and it says you need depressive affect and at least one of the other 8 symptoms of depression, and you can be categorized as having depressive episode with insufficient symptoms. It's classified under the other specified depressive disorders category. So, you get the picture. So, how are decisions made? They're made by committees. And there's a committee formed for the different categories. So for the mood disorders category, for the trauma disorder category, for the personality disorders category, there would be a committee of people who have expertise in that area. They're discussed, research is exchanged, but at the end of the day, it's a committee decision. Sometimes it's a case of he who shouts loudest. I was speaking to a mutual colleague of David's and mine, a former consultant from Southampton, who subsequently became a professor in Nottingham, in Imperial College, Peter Tyler, and he was telling me about a committee. I won't name the committee or the person, but there was a debate about whether to include a particular condition or not, and a decision was made not to include it. But at the time, and this is a few years ago, a very senior member in the American Psychiatric Association had an interest in that condition and ordered that the condition be included. And it was. And it's still in there. So it's a case of you who shouts loudest. The guiding principle when you read some of the people who are writing about this, Alan Francis is one, the other person is Jerome Wakefield. I think his background is social work, but he's a big critic of DSM, and people like him will question the utility that people include these diagnoses because they're pragmatists. They have some kind of clinical utility rather than because they're valid conditions. Now, that's not to say that ultimately they won't turn out to be valid, because, you know, knowledge evolves, people test these conditions, people test the hypotheses surrounding them, and over time it may well be that they emerge to be valid, but over time likewise the opposite may happen and they may well be ditched. I've spoken about validity. There are different kinds of validity, and the face validity, construct, concurrent, predictive. These are based on the symptoms, and you can administer questionnaires to test whether the questionnaires that claim to measure these conditions actually measure them, and that way you can prove or disprove validity. But ultimately, the only way you will be able to prove the validity of many of the conditions is with the biological markers that we talked about earlier, and we don't have any at the moment. In fact, the optimism of DSM-IV was completely misplaced, and David Kupfer, who was the chair of the DSM-V committee, when they began to deliberate about DSM-V a number of years ago, wrote, "Not one laboratory marker has been found to be specific in identifying any of the DSM-V syndromes. Epidemiologic and clinical studies have shown extremely high rates of comorbidity among the disorders." That means that several disorders will occur together, and I will come back to that because there's a bit of a misunderstanding about comorbidity. He also said that undermines the hypothesis that the syndromes represent distinct etiologies or distinct entities. Furthermore, epidemiological studies have shown a high degree of short-term diagnostic instability for many disorders. That means that if you measure them at point A and point B, the diagnosis will have changed. And with regard to treatment, lack of treatment specificity is the rule rather than the exception. So that's from the chair of the DSM-V subcommittee. And some disorders, as I've said, may come and go, and some may prove to be valid and some may not. Ones that have gone, masturbatory insanity, That went a long time ago. Homosexuality went around 1973 when DSM-IV was developed. That had been a psychiatric disorder before that. Neurotic depression went at the same time. That was the same time that major depression was identified, was described. That was DSM-III. Paraphrenia, which was a type of psychiatry of older people, went, I think, in DSM-IV. Hebephrenic schizophrenia went in DSM-IV. Masochistic personality disorder went and came back again this time. It was in DSM-III, it went from DSM-IV, and then it's back again. And Asperger's syndrome went in this issue, in this edition of DSM-V, and that was a criticism from the parents of children with Asperger's syndrome, that they will lose some of the advantages, some of the advantages and allowances that were made for children diagnosed with Asperger's. This has been absorbed into autism as part of a spectrum of disorders, but it's not named specifically in DSM. At least I couldn't find it anywhere in my pocket edition. So the other thing that's happened, as well as inventing or identifying, depending on how you view it, these new conditions that we talked about a moment ago, the diagnostic criteria have been widened. And I want to talk about major depression, because major depression has always had very wide criteria. Major depression came into being in DSM-III at the time that neurotic depression and homosexuality and all of those went. And it was Spitzer who was the chair of the committee, and he subsequently, in fact, indicated that he felt the criteria were too broad, and he regretted how broad the criteria were. He wrote a preface to a book of Jerome Wakefield's in which he stated that. Essentially, major depression consists of 5 symptoms for 2 weeks, causing distress or impairment in functioning. One or the other. You don't have to have both. The symptoms have to be clinically significant. That implies across all the disorders in DSM-V, in all the DSMs, in fact. But it doesn't mean what clinical significance means. Is it clinically significant if I go to a doctor about it? I might, after all, have had a lot of illnesses in my childhood and never be used to going to doctors and be a little overly anxious about my health when I don't need to be. Or if I don't go to the doctor, am I being over stoical? And do I not then, is it not clinically significant if I don't go to the doctor? There's no definition of clinical significance. What they use, so you have to have 5 symptoms for 2 weeks, and you have to have distress or impairment. By the way, in ICD 11, and in 10 as well, you have to have both. So it's a lower threshold here. You don't have to have both. So you can have, I can't imagine how you could have 5 symptoms and not have distress without impairment. I mean, I can see how you could have distress on its own, but how you could have impairment without distress, I can't see that. So you have to distress or functional impairment. And the duration's for 2 weeks. That's not based on any research evidence. It was a pragmatic decision to have 2 weeks. So let's take a scenario. It excludes bereavement, by the way. It excludes bereavement. In DSM-IV, in DSM-V, they've cut out the bereavement exclusion. So even if you're bereaved, you could now be diagnosed with major depression after 2 weeks, with 5 symptoms for 2 weeks. Let's take a scenario. I have a patient whose son abuses drugs, and she was referred, and he's in prison because he was distributing them as well, and she was referred to me by her GP because he was the apple of her eye, and she's extremely upset that he's in prison and serving time. She and her husband don't get on, and since the son went to prison, her husband has left her because he blames her for not chastising him enough as a child, and so they're at loggerheads about it. So she's not sleeping. She's worrying about him because being in prison is nasty. It's unpleasant. He was a quiet kind of lad, so he's a bit bullied in the prison. She's worried about him. She's thinking about him all the time. She's not eating very well because she's worried about him. She's not interested in things because she was very close to him, and she feels her life has fallen apart now that he's gone to prison. And she doesn't go out to meet her friends much because she's ashamed. I think that's a fairly reasonable way to behave if your son was in prison, boy who you were very close to was in prison. I think I'd feel like that. Yet when she came to see me, my junior doctor saw her and said she had major depression and he wanted to start her on an antidepressant. And I said, no, we'll do nothing of the kind. She doesn't have clinical depression. She's got what I would call a perfectly understandable reaction to the awful situation she finds herself in. We can try and support her insofar as you can support somebody like that. We can talk to her, or we can put her in touch with a social worker who will help her and who will encourage her perhaps to go out again. But she does not have a psychiatric illness, and I'm not going to label her as such. Parker, who runs the Black Dog Institute in Australia, he does a lot of research on depression, and he wrote a paper called Major Depression is No Longer Major, because the criteria have become so diluted and so broad that it's so easy to have major depression. Turning to post-traumatic stress disorder, I came across a paper with an amusing name recently. 636,120 ways to have post-traumatic stress disorder. That really reads, that's not a typo either, that really is 636,000 ways to have PTSD. And it was done by this couple. They got a mathematician to take all the symptoms of PTSD and look at the various combinations you could have, and you could have that many combinations. So you can have over 636,000 people with PTSD, and they'll all look different. And the same with depression. You can have hundreds of people with depression, and because there are so many symptoms and you only have to have so few, and you can have any one of the 30 or 40 listed symptoms in different combinations. So trying to get homogeneous groups together with these very broad range of spectrums is a problem. And in classification jargon, the approach of having a lot of symptoms that you can pick and choose from that are quite non-specific is known as the polythetic approach. And that will get a lot of people into the net of psychiatric illness. So you will get huge numbers who have psychiatric illness, but all the people who have psychiatric illness, but you'd also have high false positives. So people who don't have psychiatric illness but are classed as having it. The other way to do it is to have very few symptoms, but highly specific symptoms, maybe 5 or 6 symptoms that the people that are only that can only be used and that only apply, and you will have a very small group with psychiatric illness, but it will be very specific, and you will have no false positives, you'll probably have false negatives, you'll have people with psychiatric illness who will be missed. And that's the challenge in psychiatry. And psychiatric diagnosis and psychiatric epidemiology has gone for the polythetic approach, so that we get all of these large swathes of people with lots of diagnoses. One way to do it would be to weight some of the symptoms. So you would say some symptoms are more important than others, because in the polythetic approach, all symptoms are equally important. So Whether you lose weight or gain weight in depression, both are equally important. Weight loss is much more common, and it should really be given greater weight. Waking early in the morning is a significant symptom, but waking early in the morning or having difficulty getting off to sleep or waking early in the morning or oversleeping are given the same weight. So symptoms really need to be weighted. The difficulty I've already hinted at distinguishing norm and sadness. So the sadness of breaking up, a relationship that's breaking up, or of a serious physical illness hasn't really been sufficiently distinguished. And there's very little guidance provided in the classifications about how to do that. I would have thought the obvious way to do it would be to insist on both distress and dysfunction. That would be one helpful way. I'm not sure that the clinical significance criterion is helpful because, you know, people, as I've said, consult because they're excessively worried about their health and they don't need to be, or because they're being very stoic. It doesn't really tell you very much. What if they attend for psychotherapy, attend a counsellor, for example, or a therapist? Does that help? Many people with normal problems of living attend therapists. They don't necessarily have to have a psychiatric illness. I'm not saying they should attend a therapist. In fact, I'll come to that in the next slide or so, where I talk about the side effects of therapies and falsely diagnosing people. So it depends on the threshold that's applied by the individual. There isn't an objective threshold that the current system allows us to apply. So there are implications, ethical implications for the individual, and I'll talk about those in a little bit more detail in a moment. There are implications for society which I'm not going to discuss because there just isn't time to discuss all the ethical implications of the approach to diagnosis that we use. But the implications for society are largely financial ones. There's a cost to society because if people are diagnosed as needing treatment, the treatments have to be paid for, and in the public system they're paid for, whether it's psychological therapies or whether it's medications, they have to be paid for, and they're paid for by the taxpayer. So there are very definite implications for society. There are also implications for society's concerns about epidemics of psychiatric illness. You know, if we say that, you know, the world and his wife have depression, or the world and his wife suffer with anxiety disorders, I think society often gets panicky about so much psychiatric illness being about, because we're regarded as something for which we have to intervene to prevent. So again, there are costs there. If people are engaged in the legal process, there are huge implications because of financial implications. If somebody, for example, is given a diagnosis of depressive illness, and I do quite a bit of medical legal work, and if somebody is given a diagnosis of major depressive illness by one psychiatrist, and another psychiatrist who says, no, this is a normal reaction to the situation they find themselves in, so the other psychiatrist says, no, they have no psychiatric diagnosis, there's going to be a huge conundrum for the judge and for the jury who are making the award. If somebody diagnoses PTSD, they get a much bigger award than if they have major depression. So there are legal implications. Service development is often based on epidemiological studies that tell us the prevalence of psychiatric disorders in the community, and we build our services around them. We provide psychological services, we provide child psychiatry services, adult services, inpatient bed numbers, day hospitals, etc. And if we base it on the premise of psychiatric disorders, but if what we're actually measuring isn't necessarily psychiatric disorder as even moderate severity, but psychiatric disorder that may not even be psychiatric disorder, that has huge implications, and it questions the foundation on which these services will be developed. Implications for scientific endeavour. We heard about randomised control trials. So if you're doing a trial of an antidepressant, for example, you want to make sure that you test it on people who have a depressive illness clearly defined and clearly specified. I think the problem now, and one of the reasons why antidepressants only work in some people in the trials, is because there are some people in there who actually don't have depressive illness, who maybe have adjustment disorders or may not even have psychiatric disorders at all, conditions that don't need or respond to antidepressants. What happens if if some conditions are in one classification and not in the other. So if Asperger's remains in ICD-11, but is taken out of, and has been taken out of DSM-IV, what happens there? What happens in international studies? What happens cross-continental research? It really boggles the mind what will happen. And then there are implications for the profession. I'm going to discuss the individual and the profession very briefly before I conclude. The implications for the person themselves. If how you think about yourself, if you're classified as having a psychiatric disorder, you see yourself in a particular way. But supposing you don't have that disorder you've been told you have, supposing what you've got is a perfectly normal reaction to stress, you're going to feel differently about yourself. You're not an ill person with, and I think the word broken was used this morning by a few of the speakers I heard. You're a broken person. On the other hand, if you've got a normal reaction to stress and you're experiencing normal symptoms, you're somebody who is resilient and who is showing a healthy response. And they're two very contrasting self-perceptions. If you apply for a mortgage and you've been given a diagnosis of psychiatric illness, you will almost certainly have to get a letter from your GP to say that you're going to be able to pay the mortgage, you're going to be well enough to work. If you're looking for car insurance, you're going to have to persuade them that you're not going to die by suicide, so that they're able to insure you, or that you're not going to drive your car so as to end your life. And if you're getting married or in a relationship, your partner may have a very different view of you if you've got a psychiatric illness. They may well be very much more protective and solicitous of you than if what you're experiencing is a normal reaction to stress. I'm always amazed when patients who've, say, recovered from depression, and I interview their spouses, their partners, and the partners will say, well, what can I do to help to prevent this happening again? But supposing there is nothing to prevent happening again, supposing they don't actually have a psychiatric illness, but they have been led to believe that they have, there are all kinds of, I think, relationship implications for that. Never mind what happens if they want their marriage annulled and then come to a psychiatrist. And some people still try to get their marriages annulled, and I've seen quite a few of them on the grounds of psychiatric illness prior to marriage. Treatment implications. Well, if people are prescribed medication or just diagnosed, they may well be prescribed medications. And medications, antidepressants, all of them have well-known side effects. David spoke about some of them during his talk. But they may be unnecessarily prescribed psychological treatments as well. And psychological treatments have side effects. I think Trevor mentioned some of them in his talk. And a systematic review by Mike Crawford on the subject, published in the British Journal of Psychiatry in 2016, identified some of those. And there is a growing literature on the dangers of psychological treatment when they're prescribed inappropriately. For example, some studies show that if people who are experiencing normal bereavement tend for counselling, it actually increases their risk of having a pathological grief reaction subsequently, because you disrupt the normal grieving pattern. Critical incident stress debriefing, which was used in the Defence Forces after major incidents, has been shown to increase the likelihood of developing PTSD when it's given in one session and when it's given compulsorily. So that all of these issues around psychological treatments that we weren't aware of. So you don't want to be prescribing people treatments, either talking therapies or medications, who don't need them. And of course, there may not be any treatments for the newly discovered disorders like reactive attachment disorder or disinhibited attachment disorders. I don't know if there are any treatments for them. I haven't seen any in the reading around that I've been doing. And of course, for some diagnosis can be an excuse not to offer treatment in particular personality disorder. And for the profession, it brings the profession into disrepute if we're plucking conditions out of the air that aren't adequately validated. There's also the issue of links to the pharma industry. Have the pharmaceutical industry played some role in some of these conditions? If you Google some conditions like bipolar disorder in children, you will see allegations in Google that certain psychiatrists have been enthralled to the pharmaceutical industry. I'm not going to mention their names because I don't want to be defamed. I don't want Anscombe to be defamed above all. But these people, there are some people who've been brought before Senate committees in the US. Most of them are still in post, so I don't know whether the allegations are correct or not. But there have been allegations made about not disclosing, not making accurate disclosure of financial benefits from the pharmaceutical industry in the context of drug trials. And finally, there's politicisation. And psychiatry doesn't have a great history in relation to politicisation. In the USSR, psychiatrists colluded with diagnosing with the politicians there and with the government and with the security forces in diagnosing sluggish schizophrenia in people who opposed the regime, the communist regime. And sluggish schizophrenia was diagnosed by psychiatrists, and people were incarcerated in psychiatric hospitals and given psychotropic medication, and there's quite a big literature on it. In China, in particular, the persecution of Falun Gong resulted in a diagnosis of political dangerousness being made, and they developed units called the Anscombe units, which were called peace and health units, where these people were incarcerated under the supervision of psychiatrists. Derek Summerfield, who is a psychiatrist, wrote that PTSD came about and was diagnosed, the term PTSD came to the fore in the 70s in the US because of government concerns and worries about the number of veterans who were coming back damaged. And so the term post-traumatic stress disorder, which before that it had a different name, I think it was called railway elbow or railway shoulder or something like that. What was it called in the First World War? Anyway, the title changed because the government wanted to change the title as a way of picking up a group of people about whom they felt guilty for sending off to the war. Gulf War syndrome has been a controversial one, and to be fair, I think psychiatry has largely shied away, and in particular Simon Wesley has criticised the diagnosis of Gulf War syndrome, which I think was made largely by military personnel rather than by psychiatrists. The government in this country a few years ago invented a condition called Dangerous and Severe Personality Disorder, DSPD, in which psychiatrists were asked to take people into specially built units, people who might be dangerous, and to treat them. Thankfully, psychiatrists revolted against that, and so that didn't get anywhere. And we've recently had huge controversy about ME, and chronic fatigue syndrome, and a drug trial, not a drug trial, I beg your pardon, I take that back, a trial of psychological and exercise therapy. There's always been controversy about whether ME or chronic fatigue syndrome is a psychiatric condition or a physical condition. The ME people, school believe it's a physical, post-viral condition, viral condition. Chronic fatigue syndrome, people believe it's a psychological condition. And the case study involved one psychiatrist from Oxford and two from London Hospital, and they did it and it was published, and it caused an uproar because it suggested that people who took part, who benefited from the study, benefited from psychological therapy and exercise therapy, and that a large percentage of them did benefit and therefore should undergo these therapies before they were put on disability. The people who supported the physical, the biological model And there are some psychologists and psychiatrists in that group disagreed. And the upshot was a huge controversy that resulted in a level of debate, among other things. There were the House of Commons asked, questions were asked. There were exchanges, including this one. I'm not sure how Wittgenstein, with his use of language, would feel about this. But anyway, you have long been one of my intellectual heroes, but in your attempt to bully me, you moved from a Trotskyite in your younger days to a disgusting old-fart neoliberal hypocrite. And that was an exchange between two professors of psychology, Professor Coyne and Professor Smith, who took different views. Professor Smith was a member of the editorial board of a journal that was going to devote a whole issue to criticising the PACE study. So they were pro the ME biological people, and Jim Coyne, insofar as I worked it out, I took the other position. I think that they were the polarised positions, and this was the upshot. If you just Google the PACE study, you will be astonished at what you see in it. So, in conclusion, new diagnoses are proliferating. Their diagnostic criteria are being widened in some conditions. There's poor validation of most of the conditions. I haven't time obviously to talk about the sloppy application of some of the criteria in clinical practice. There's a wonderful paper by Slavny and McHugh in JAMA in 2005, and I know one of his acolytes is over there. We were talking about it last evening, and we're speaking tomorrow. And comorbidity, which is this issue of multiple diagnoses. So if you've got depression and you've got anxiety symptoms, you will be diagnosed as having both a depressive illness and an anxiety disorder. If you've got, and you really shouldn't be, it's all part of the one spectrum. They should all be in the one spectrum, they should all be one condition. But comorbidity is another talk for another day. I think we should avoid nihilism, diagnostic nihilism. I don't think that psychiatric diagnoses should be abolished. I'm not saying that for one moment, because I believe they're important, but we have to tighten up on them. And Dan Stein suggested that the only categories we should have in the body of any of these classifications are those that at least have what's called prognostic or predictive validity, and those that have some evidence of psychobiological disruption, like bipolar disorder and schizophrenia, and those that have shown that we can predict response to treatment. All the others should be in an appendix for further study, which in the case of DSM would probably mean that there would be 4 conditions in the body and the other 335 would be in the appendix. We should I think we should lump together the conditions rather than splitting them into subtypes, because it's endlessly confusing and we don't have enough information to suggest they're actually independent of each other. I think we should return to the study of phenomenology so that we can carefully weigh and measure and evaluate the symptoms people are describing, and not just do it sloppily in the way that McHugh and Slavny have expressed, about which they express their concerns. And I think we should weight some of the symptoms, and I think we should avoid regarding conditions, trendy behaviours as disorders like gaming addiction. And I remember when it emerged that, what's his name, he was a famous actor who diagnosed himself as having sex addiction, and then it appeared in some classification. I think we really need to avoid that. Thank you for having the patience.